one thing to highlight that the impact of endometriosis on the economy is similar to diabetes or Crohn's disease. So it's really huge. And a lot of this impact is not seen in the health service. It's seen somewhere else where patients call off sick and they leave work or they fail their study at the university because of the chronic pelvic pain.
But I was still finding myself in pain, and I had symptoms like dizziness, low mood, lack of appetite, and contraction type pains. Not having given birth, that's the only way I could describe them.
And I think a lot of patients who have been labeled as normal, even by endometriosis specialists, have adenomyosis.
I'm really interested to know how much the internet played in you being able to kind of find this information about endometriosis when you felt kind of a bit let down by the health system.
And endometriosis can affect fertility in two ways. The first one.
Another question is, if someone has already had a laparoscopy and an excision of the endometriosis in the same surgery, what is then recommended for future surgeries? And if someone is in so much pain, is it recommended for them to have another excision surgery? And how do they decide that?
Hi everyone, and welcome to the first instalment of the JFPR Breaking the Silence Health Panel Discussions. I'm Liz Connor, I'm a health and wellbeing journalist and panel moderator. So in a climate where health misinformation creates confusion, NHS waiting lists are longer than ever and questions can often go unanswered, we've devised this new educational series to raise awareness and offer extra support to those impacted by some of the most common health issues facing people in the UK today. So first up, we're tackling endometriosis. This is a really common but often misunderstood and underdiagnosed condition that affects millions of women worldwide. And it's estimated that 1 in 10 women suffer from it. And it's also the second most common gynecological condition in the UK. So our special guest today is Mathilde Barker, who is a TikTok influencer and dancer who has built up a huge following online after sharing her complicated journey to diagnosis and treatment. Joining myself and Mathilde is Mr Zaid Hasafa, who is a leading gynaecologist specialising in endometriosis from the New Victoria Hospital in Surrey. So hi guys, really good to have you.
Hello.
Hello.
So in this discussion, we're going to be shedding light on the common reasons for delayed endometriosis diagnosis and better understanding how women can advocate for themselves and access the necessary treatment that they need. So Mathilde, thank you so much for being here. It's really exciting to have you. To kick things off, I'd really love to know if you could share a bit about your journey with endometriosis and also how you offer insights on the condition with your followers.
Of course, thank you for having me. So my name is Mathilde. I'm a 20-year-old student at a musical theatre college in Surrey, and I was diagnosed with endometriosis about 9 months ago now, April of last year. And I suffered with symptoms 5 years prior to my diagnosis. And along the way, I have documented my journey on my social media, Instagram and TikTok, where I have gained a lot of questions from followers who are suffering with same symptoms and are wondering if they have endometriosis too.
Yeah, it's so powerful actually to have that platform and connect with people. And Zaid, it would be great if you could kind of introduce yourself too and let us know kind of your expertise in this area.
Okay. Well, thank you for having me for this discussion. This is really important for everybody to listen to. I'm Mr. Hasafa, Zaid Hasafa, one of the gynecologists in Kingston Hospital and the lead for minimal access and laparoscopic surgery with my main interest of endometriosis. So to start with, endometriosis is we can define endometriosis to start with, and endometriosis is a common benign disease. Benign means it's not cancerous, and it affects 1 out of 10 women, as you pointed out. So there are millions of patients in the world, and the impact, one thing to highlight, that the impact of endometriosis on the economy is similar to diabetes or Crohn's disease. So it's really huge. And a lot of this impact is not seen in the health service. It's seen somewhere else where patients call off sick and they leave work or they fail their study at the university because of the chronic pelvic pain. The common symptoms for endometriosis is painful periods, pelvic pain, painful sexual intercourse, or pain in the back passage when the patients have periods. The key element of the symptoms is the cyclical pattern. So endometriosis as a definition means the presence of the lining of the womb cells outside the womb. And that's endometriosis. And if I can share with you a simple slide just to show you what it means, just to help you understand the disease. This is just a simple diagram to show you. So endometriosis means the presence of the lining of the womb cells outside the womb, as you can see on the left-hand side. The middle one is a version of endometriosis called adenomyosis, and that means the presence of the lining of the womb cells within the muscle of the uterus. And that version of endometriosis is commonly underdiagnosed even within endometriosis centers, unfortunately. The endometrioma is another version of endometriosis, and that's the one, the drawing on the right-hand side of the screen, and that's when the endometriosis affects the ovary and causes a cyst on the ovary.
So Mathilde, you've been really vocal about your painful experience with endometriosis on social media. Could you share a little bit about what your symptoms were like?
Of course. So my symptoms started out with intense back pain, and with the volume of dance that I was doing, I thought that it was linked to this. And after a dance show, I actually presented at A&E with how severe the pain was. And they suggested it was a muscle strain to give it 4 to 6 weeks. But I was still finding myself in pain, and I had symptoms like dizziness, low mood, lack of appetite, and contraction type pains. Not having given birth, that's the only way I could describe them, during times when my period were. But at the time, I wasn't aware that it was a cycle. The pain came and went without really knowing why or how. And it wasn't until I saw my osteopath at the current college I'm at, who asked me to make sort of like a journal of when my pain was, and asked how it aligned with my menstrual cycle. And from then, I then got referred to my local gynaecologist department, and we went from there.
Yeah. And it's frustrating to hear that you kind of had to go away and do that research yourself and kind of take a look at your symptoms and kind of match those up with your menstrual cycle and present those symptoms to your GP and say, hey, I think something isn't quite right here. So Zaid, I'm really interested to know, is Mathilde's experience quite common, and are there any of the symptoms that you think women should be aware of?
Yeah, the story from Mathilde is almost like a copy-paste, that what I hear, almost like a recording, that every patient say exactly the same things. I mean, there is a combination of symptoms that Mathilde said, but there are other symptoms that Mathilde has not mentioned that some other patients say, but it's normally the same symptoms. So patients normally say that they have pelvic pain that gets worse when that's on and off to start with. The pain gets worse when they have periods. The pain radiates to the back. A lot of patients say that the pain radiates to the thigh as well, to the front of the thigh. Some patients, they say that it radiates to the back of the thigh. And this pain is cyclical, so it happens every month around the time of the period and peaks during the period and then gradually gets better. And that's how the endometriosis starts. And then what happens is that some patients will have painful sexual intercourse, pain in the back passage if the endometriosis is near the bowel at the time of the period. So they have sharp pain in the back passage, and that's called dyschezia. And the pain gradually gets worse and becomes longer and longer and longer during the period. So out of the 28 days, they will have 7 days in pain, and then this will expand to be 15 days, and then later on during their reproductive life, the pain becomes almost daily. But then they will still have the peak of the pain during the cycle. So they will still have worsening pain when they have periods. And that follows how the disease progresses pathologically. The disease starts in areas where there are nerves and they give them pain. And then gradually, with time, the endometriosis builds more adhesions and scarring. And the scarring gives them then pain all the time, but it's still peak during periods. One more thing that I have seen over and over with endometriosis pain, especially when they have bowel symptoms, is that when patients present to the GP or even to a gynecologist, and that's really sad to hear, and then they get told that this is more likely to be bowel related problem. And a lot of my patients with severe bowel endometriosis, they get referred to see a bowel surgeon and they get a colonoscopy. And because the endometriosis is on the other side of the bowel, the colonoscopy will be normal. And I hear this all the time, that I've been to a colorectal surgeon and they checked my bowel, I had colonoscopy, and it's all normal. And when the patients get normal investigations, even worse than having no investigations, because then sometimes the clinicians or the family turn to that patient and say that it's all in your mind, it's all in your head, you don't have any problem, it's all fine. And then the patient will continue to be in agony. I see it sometimes even almost like a life sentence when they have the wrong investigations and they get told everything is normal, and when everything is far from normal and they have severe endometriosis.
Yeah, it's so frustrating. I mean, I feel like Mathilde kind of really explained it really well by saying it's like being in labor, having never been, given birth before, but it's that level of pain. And I can imagine, as you say, it must be so frustrating for many women. Would you say that one of the key symptoms to look out for then is, pain outside of your normal monthly cycle? Because lots of women obviously suffer with period pains, but obviously, it's quite abnormal to have those continue outside of the period window.
I wouldn't specify pain outside the period. I would say that pain during menstrual cycle is the most important element to it. When they have pain outside the cycle as well as the pain during cycle, it might mean that they have severe form of endometriosis that's caused adhesions, which means scarring, that started to give them pain all the time, plus worse pain during periods, if that makes sense.
Mm-hmm. And how would you kind of describe that pain? Because I think this is like an area of confusion for women, in that we're told that period pains are normal. But obviously, if you're suffering with endometriosis, it's something that you can get support for.
Yeah, so the question is to me, is that right?
Yeah, kind of,
Yes.
in terms of pain, like, how do you assess that pain? How do you know what is endometriosis pain, what's normal for you?
It's a difficult question to answer because, in my opinion, a lot of adenomyosis, which is a version of endometriosis, is underlooked and underdiagnosed. And I think a lot of patients who have been labeled as normal, even by endometriosis specialists, have adenomyosis. So in my opinion, if the pain is mild, which means that they don't need more than paracetamol, for example, for a day or two, that I would say acceptable level of symptoms that patients get with periods. But anything outside of that, if the pain is more than a day or two, if they call off sick, for example, they cannot go to work, if the pain lasts longer, if they need more painkillers than simple paracetamol, then I would say there is a high chance that patient will have endometriosis or adenomyosis. The problem with the endometriosis is that the severity of endometriosis does not correlate well with the symptoms. So sometimes you might have mild disease, but like a spot or an area of endometriosis that has grown on over a nerve. And then the patient will be in agony because it's on a nerve. While sometimes patients with severe disease, they have some symptoms, but they're not that bad. So the correlation between the severity of the disease and the severity of the symptoms is not good. But if you, for example, collect 100 patients, and if you ask them if they have painful periods, dyschezia, which is the pain in the back passage when they have periods, and painful sexual intercourse, then maybe 80% of them or 90% will have endometriosis.
That's really interesting, and interesting to hear that, you know, there's different kind of types of endometriosis. You kind of touched on it there, but I'd be really interested to hear kind of more about the difference between I'm going to butcher this.
Adenomyosis.
Adenomyosis and endometriosis.
Yeah, can I just share with you the screen again, just to show you the diagram? Yeah. So if you see the first, if you see the first drawing on the, can you see my slides or?
Yes, we can, yeah.
Yeah. So if you see the first diagram on the left, there is a uterus and there is lining of the womb of the uterus, which is the red line. And if you see the patch on the right side of the diagram where my cursor is, and that's the endometriosis. So if you see the uterus here is a normal shape, it's symmetrical, and is not bigger. If you go to the next diagram in the middle, you will see that the uterus is larger, asymmetrical, and irregular on the outside. And that's because there are cells of endometriosis within the muscle of the uterus. The difficulty with the adenomyosis is that clinicians or specialists say that it's best to be assessed with the MRI scan, followed by laparoscopy, followed by ultrasound. But there are no criteria to say how to diagnose this adenomyosis when you do laparoscopy. So it depends on the opinion of the specialist when they look at the uterus. On the MRI scan, the criteria to diagnose adenomyosis is so strict to the extent that I've seen a lot of patients when the MRI scan reported possible adenomyosis. In my opinion, those patients definitely had adenomyosis. So when the report says possible adenomyosis, it is definitely adenomyosis. And I know that for sure because some of those patients had hysterectomy, which means removal of the uterus, and the uterus was assessed in the lab and was confirmed to have adenomyosis.
That's really interesting. So, you know, I think a lot of people won't even know that there are, you know, 2 different types to be on the lookout for.
Or 3. There is the third version.
Yeah,
sorry, is the endometrioma. Yes.
Yeah. So I think that's really helpful. If we jump back off screen sharing, I will move into the next question. So we talked a little bit about diagnosis times. Zaid, I think you said it was around 8 to 10 years for the average woman to get a diagnosis. So why is it that the diagnosis time is so long?
So the one of the main reasons for the delay in the diagnosis was the awareness between patients, or between the public, in the public, which has got significantly better in the last 15 years. So there are now more GPs who are aware of the possible problems, and they will refer the patient to the appropriate specialist to have the investigations. The other problem was at the GP level, or the primary care, where patients reported that they were not listened to. And that also has changed and improved. But now the problem that in my opinion, the biggest problem to improve the diagnosis or to speed up the diagnosis of endometriosis is at the general gynecologist level. And that's what I would call the secondary care. So basically, a patient is aware of the possible endometriosis, they get referred to the GP refers them to the general gynecologist, but then the general gynecologist might not address the endometriosis properly. So normally when I see patients with pelvic pain and they have endometriosis symptoms, I discuss with them 4 main options. And these options might not be suitable for some patients. Some other options might be more suitable. So normally what I say is that this is if we assume you have endometriosis, you have 4 options. One is to do nothing because it's a benign disease. You can leave it alone as long as we understand that the collateral damage from endometriosis is not putting any organ at risk, such as ureter, which is the tube between kidney and bladder, or the fertility organs or the bowel. So, but do nothing is one option. Another option would be to have a laparoscopy, which is keyhole surgery, to look inside the abdomen, the tummy, to see if you have endometriosis or not. And that's the best way for the diagnosis and treatment. The third option would be to have hormonal suppression to endometriosis. And the aim of this hormonal suppression for endometriosis is to stop the periods and stop the activity of the endometriosis. So this treatment will not take away the disease, will not remove the disease, but it will control it. The advantage of that is that patients will avoid the surgery and the surgical risks, but they will not have the diagnosis confirmed or a treatment. And the fourth option is conceiving. The idea of hormonal suppression came from the improvement of symptoms that patients notice when they are pregnant. So the hormonal suppression is mimicking pregnancy. So pregnancy is good for endometriosis, but again, it does not remove the endometriosis, does not take it away. It's like having a break from the endometriosis when patients are pregnant and breastfeeding because they have no periods. So to go back to your question about the reason for the delay, so I think there are 3 layers for the reason of the delay. Public awareness, primary care, and the GP care, which I think improved, but now the main problem is in the general gynecologist awareness and consultation and offering a laparoscopy. And I see this often, that like I saw a patient last week, when a patient who is 25 has been in pain for a long time, and she's got normal body weight, there's no increased risk of surgical risks. And one of the senior trainees who saw that patient wrote at the conclusion, laparoscopy is not indicated. So when I saw this, I was really sad to see it. Why laparoscopy is not indicated? It should be a patient's option. It should be that if I saw that patient, I would say, I discussed the 4 options and I named these options. I discussed the risk of the surgery, and patient chose to have a laparoscopy. You know, when you see laparoscopy is not indicated, it means that that clinician is sure that that patient doesn't have endometriosis. And when I looked at the symptoms, she basically that patient had every symptoms of endometriosis. So that's, I think, where the problem is. And I think I'm working on an educational website where it's going to be built mainly for general gynecologists to improve their diagnostic ability and the care and the secondary level, which is the gynecologist, general gynecologist.
That's really interesting, because it's like, how can you be sure, particularly if people are suffering with symptoms?
Unless if you do laparoscopy, absolutely.
Exactly. And Mathilde, you obviously have lived experience with this condition. So what was diagnosis like for you, and did you find that there were any challenges to getting that diagnosis?
Yes. So I went through 5 years of symptoms before getting my definitive diagnosis. And it was 5 years of repeated GP appointments, A&E visits, days in bed, not being able to move, not knowing what was wrong with me, consequently having a low mood, a very negative life, basically not a very good quality of life because of how much pain I was in. And I would repeatedly get in touch with my local surgery to get a GP appointment. And after a while, they were just saying, like, it's your period. Women are in pain when you get your period. Like, it's normal. But something in me was telling me, your pain isn't normal. Like, I just knew, being in my body, I just knew that this is not the level of pain that one should be in on their period. So I continued going back to the GP, and we tried different methods. So the first one was physio. And I had a few courses of physio for muscular back pain. And I did, being a dancer, I'm very active. I stretch a lot. So this physio was basically like a replication of stretches I would do in like warm-ups, cool downs. And I knew that, like, I was giving it a go because maybe it was a muscular thing, but deep down I knew that it wasn't quite right. So then I went privately through an osteopath who was recommended to me by the NHS, and they said, if you want to be seen quicker, and we have an in-house osteopath. So then I started seeing this osteopath who diagnosed me with a sacroiliac joint condition where it basically seized, and they called it a sprained sacroiliac joint. So then, instead of thinking it was muscular, I understood that, like, my muscles tightened around that area because of the strain on my joint. And this osteopath performed movements on the bottom of my spine to release the tension. And he basically said that my spine was a bit like twisted at the bottom, causing this pain, which I've come to find out wasn't the case, because I don't have any structural issue in my bones in my spine and around my sacroiliac joint. So I went through about a year of treatment with this osteopath, and after it not getting better, I went back to my GP. And at this point, I was sitting out of dance classes, taking like months off, traveling to dance just to sit in the corner just to watch. And I was so lost, and I was told that stopping dance would help my back because I was overdoing it by dancing. So it was a really low time for me because I was unsure of what was going on with my body, as well as the hormonal mess that's going on in my head, around like my pelvis with my period. So then I moved to college. So by now I had left home, and I was still getting really intense pain. And having started full-time college, it was an issue because I wasn't able to perform in the training that I want to do as a career. So it was becoming a real issue. I went to my GP and I was like, listen, this is severe. I cannot be in this much pain. So we tried the contraceptive pill, to basically control my period, hoping for it to either reduce the pain or stop it completely. And I'm not sure what happened with this pill, but I had to rapidly come off it due to a huge decline in mental health, as well as it not helping my physical pains at all. And at this point, I felt like we had gone back to square one. And they did offer me the Mirena coil at this point, in which I did consider, but I went for the contraceptive pill option at this moment in time. Then around about the same time, I was put on mefenamic acid, which is a stronger pain relief for periods, as I was at the point where ibuprofen, paracetamol, your over-the-counter pain relief wasn't doing anything for me. And even when I sit with a hot water bottle, it does reduce the pain in a sense that it numbs the area, but it's just a temporary comfort solution for me. So I was at a point where I needed stronger medication to ease my pains. So I was put on mefenamic acid, which nowadays doesn't help me because I feel like I've become almost immune to it because the pains are stronger. And when I take the medication, it doesn't unfortunately ease the pains. So then I went to my college osteopath, and this is when they sent me to be referred to gynecology. So I went to my GP and I said, I know I've been so much about this pain in my back and my pelvis. I think it's related to my period. Please, can you refer me to my local gynecologist department? So I went there and we did an initial appointment, like a checkup. And from then I was offered an MRI, which I took. And from this MRI, it came back clear, no sign of anything. And I've heard that it's quite common to not be able to see it through an MRI. So I thought, okay, I still might have it, so I'm going to keep pushing. So I went back to this gynecologist and I had like a checkup appointment a few months later. And I said, my symptoms haven't eased. Please, can I have another test? So they sent me for an ultrasound, which again came up with nothing. And I did a bit of research, and it's also common for endometriosis to not show up on an MRI or ultrasound. And at this point, having spoken to my osteopath, I was aware with what endometriosis was, but before that time, I didn't know. So it wasn't even something I had considered could have been wrong with me. And it wasn't until I spoke to my osteopath at college who said, this could be endometriosis. So after the ultrasound, I had a sit down with the gynecologist, and my mum actually travelled down from the north to be with me for that appointment because I was in such an like I was just a bit lost. So when I went into these appointments, I didn't really know what the right questions were to ask, and sometimes I felt under pressure, and not in a way that the specialists would disregard what I was saying, just in a way that I found it hard to communicate my actual symptoms. So having my mum there was really helpful to make sure I didn't miss anything. And we came to a conclusion in that appointment that I was going to be sent for a laparoscopy, which is the keyhole surgery to help diagnose it. So then I had the keyhole surgery about 5-6 months after that appointment, in which they made 4 incisions, and they diagnosed me with endometriosis, and they also removed it in the same surgery and fitted the Mirena coil.
Wow. I mean, yeah, it's so great that your mum came with you to that appointment. And I can imagine after you've had so many kind of misdiagnoses that there must be so much pressure, as you say, in those chats with GPs and specialists to make sure that you communicate your symptoms. I'm really interested to know like how much the internet played in, you know, you being able to kind of find this information about endometriosis when you felt kind of a bit let down by the health system.
Yeah, so as I create content and have a platform that I can basically speak to a large number of people, I would put my symptoms on or just say I was having a down day and this is what I was experiencing. And I did get a few comments prior to my diagnosis saying, have you considered getting checked for endometriosis? This sounds quite similar to those symptoms. And that is when I did realise, as well as my osteopath pointing me in the right direction, that endometriosis could be a possibility. And I'm lucky to have had that platform of people and that network to kind of support me in that. And then when I was doing my research as well, I would type my symptoms in, and I know that you can come to a vast range of conclusions on the internet, and it can be kind of dangerous when you do search symptoms on Google. But I found that when I did research, I did find a lot out that I didn't know. And it was interesting to match up my day-to-day symptoms with things that I was reading. And it gave me comfort in knowing that maybe I was finding an answer. And I didn't assume anything from what I read online, but I just kept it in mind for my next appointments to be more informed with what I was talking about.
Yeah, completely. It seems like there's such a strong, active community in this endometriosis space because it is so underdiagnosed. And we've talked a little bit about how, you had surgery. Was that an easy decision-making process? Like, were you kind of at the point where you were like, I just need to get answers and I am so happy to go and get this done now?
Yeah, so I was in my second year of college when I was offered the surgery, and it's a recovery that's not easy, especially if you do have that removal work done. I think my recovery time was about 8 weeks. So I was aware that I was going to have to take some time out of college to have this surgery. But at this point, I was in so much pain and lost for answers that I was willing to do anything that the specialists were suggesting for me to find an answer. And when I did have the surgery, I can't describe the relief I felt having been diagnosed, even though it sounds awful that I was pleased to know. Just the mental luggage that's just lifted off your shoulders, knowing that it wasn't in your head the whole time and that your pain was genuine and that there's physical proof that those symptoms were endometriosis. I cannot tell you how overwhelmed and happy I was to have found out and to finally be able to explain to people what my symptoms are, and having that answer was just such a relief.
Yeah, I can imagine. It just seems like there's such a big emotional impact with having endometriosis. So I can imagine that kind of relief. I'd like to talk a little bit about fertility and family planning as well. I know that endometriosis can have an effect on that. So Zaid, could you kind of explain a little bit about this in more detail?
Yeah, so the endometriosis is a disease that causes scarring, and it's invasive to other structures. So it can damage the fertility organs as well as ureter, as I said, or the bowel. But the fertility organs are the most fragile structures in the pelvis. And endometriosis can affect fertility in two ways. The first one is by the scarring that can happen, especially if the endometriosis position is near the tubes and ovaries. The tubes are easily damaged because they're very fragile structures, and the damage to the tube can obstruct the fallopian tubes, and that can increase risk of ectopic pregnancy or conceiving in the first place. The other way that endometriosis affects conception is the damage that happens to the ovarian reserve. So when the endometriosis is near the ovary, it catches the ovary, and that can cause the third version that I showed you earlier on the slide, called endometrioma. And when that happens, the ovarian reserve drops. Women are born with a certain ovarian reserve, and when they start having periods, this ovarian reserve drops every time they ovulate, and the ovarian reserve drops with age till they reach the menopause. With endometriosis, the disease drops the ovarian reserve too early, or causes damage to ovarian reserve. And there is another way also of affecting the chances to conceive is the chronic inflammation in the pelvis. So even with mild disease, with mild endometriosis, the inflammation that the disease causes affects the chances of the fertilization of the egg and having the embryo, etc. So even when there is very simple endometriosis, removing that helps the chances to conceive.
It's really interesting to know. I'm conscious of time, so I'm moving through my questions at rapid speed. But as Mathilde kind of touched on, it can be difficult to get a diagnosis in your GP. So Zaid, I'm keen to know, what are your top tips for patients to advocate for themselves if they think they might have endometriosis?
So as I said earlier, the main symptoms that they should pay attention to: excessively painful periods, pelvic pain, especially if it's cyclical. Some patients might have diaphragmatic endometriosis, and they might have pain in the upper part of the abdomen, but that pain will also be cyclical. So it happens every month, for example, like around the same time of the month. Painful sexual intercourse, pain in the back passage when they have periods. So these kind of the main symptoms that should alarm the patients to at least have a chat about it. They don't have to have a laparoscopy. The laparoscopy is the best way to diagnose it, but I'm not saying that everybody should have a laparoscopy, but they should at least have the discussion, and they should be aware of such possibility. My niece is 19 years old. She's in medical school, and I diagnosed her with endometriosis when she was 15 or 16. Her mother is a GP, and she has not had a laparoscopy yet. We're managing her symptoms with medications. She doesn't want to have a laparoscopy, but at least she knows about it and she's managing it differently. So that's what I would say, that every patient with these symptoms should be at least aware of it and should also have a discussion with a specialist about it.
Yeah, right. It's like empowering the patient so that they, have all the informed facts to then make a decision that's right for them.
Yes.
So all this week, Mathilde has been asking her audience on TikTok and Instagram to send in their questions that they'd like to ask a gynecologist. So I'm going to pass over to Mathilde, who is going to bring us some follow-up questions.
Hey, thank you very much. So the first one is, having had the coil fitted after my laparoscopy, I'm still getting pain every month and on a day-to-day basis. How can I manage this?
So has the pain improved after the laparoscopy?
I don't think so in this case.
Okay, so sometimes so if that patient has not had a laparoscopy, they should have a laparoscopy to make sure that the diagnosis is correct. The Mirena coil is one way of hormonal of the treating endometriosis, which I call hormonal suppression to endometriosis, but it is associated with the lowest dose of hormonal suppression that is often not enough to suppress endometriosis or adenomyosis. So what I would suggest that a patient with a Mirena could add the mini pill on top of the Mirena, or there is a new drug called Dianogest, Dienogest. And this drug is the best drug available for endometriosis. So they can add that drug, that medication to the Mirena, or the mini pill to the Mirena. And the aim of that treatment is to find how the symptoms respond when there is no period. So once the patient achieves no period, I would expect that if the endometriosis is the cause of the pain, that all of their symptoms should improve. If that doesn't happen, it might mean that these symptoms are not endometriosis related. So the symptoms are not always caused by endometriosis.
Thank you. Another one is, why is it a recommended solution to get pregnant whilst endometriosis can cause issues with getting pregnant and fertility?
So the endometriosis makes it hard for patients to conceive. And that's because of the scarring that can happen or the low ovarian reserve. But once the pregnancy establishes and starts, there is a hormone called progesterone. And the progesterone is what calms down the endometriosis. What drives the endometriosis is another female hormone called estrogen. So estrogen is what activates and stimulates the endometriosis, while progesterone is what calms down the endometriosis. And when patients are pregnant, they get about at least 20 folds higher progesterone level in their circulation compared to the non-pregnancy time.
Okay, thank you. Another question that's common is a lot of people are suggested to go on a early menopause, like an inducing injection for about 6 to 9 months to manage this pain. What are the risks of that on your natural body menstrual cycle and future fertility? And is are the hormones affected by this injection?
Yeah, so what I meant so far in my discussion about hormonal suppression to endometriosis does not include the drugs that induce menopause. So the drugs that induce menopause are more drastic, and they can only be used for 6 months. And the main reason, maximum 6 months, and the main reason for this is that those drugs can weaken the bones. And can also increase the risk of heart issues, or because basically you're making someone young menopausal. So it's not ideal for a long-term solution. As a specialist, I only use these drugs for certain cases before the operation if the endometriosis is really severe. So we use it like for 2 to 3 months before the surgery and 2 to 3 months after the surgery. And that's to reduce the inflammation, so that when we do the excision of endometriosis, it's more clear where is the disease as compared to the scar tissue. But for a long-term solution, I don't think it's a good idea to use these injections. Normally, it's an injection once a month to give temporary menopause. There is a new drug, however, that's a tablet version of this injection that has got HRT with the same medication. In my opinion, I don't think this is a good idea, because the HRT will have estrogen, and the estrogen stimulates the endometriosis. So in the same medication, you have a drug or a hormone to give menopause, and the other drug, which is estrogen, that stimulates the endometriosis. So it doesn't make sense to me to give something that stimulates the endometriosis and another drug, another hormone that gives menopause in the same drug. So I don't think it's a good idea to use these kind of medications for a long-term management.
Yeah, thank you. Another question is, if someone has already had a laparoscopy and an excision of the endometriosis in the same surgery, what is then recommended for future surgeries? And if someone is in so much pain, is it recommended for them to have another excision surgery? And how do they decide that?
Okay, so that's regarding the recurrence of endometriosis. So the British Society for Gynaecologist, which is the national body to regulate and to control the high-risk operations for endometriosis, looked at over 8,000 patients in 50 endometriosis centers within 12 years. So they collected data for thousands of patients. And they looked at the first question that they wanted to answer, which was believed to be a myth 20 years ago, was the question about whether the excision of endometriosis improves symptoms or not. So there was a group of people 20 years ago who said, you're wasting your time doing this long operations for severe endometriosis patients. They will never get better. And the first question was shocking for these people, or a big surprise, that the quality of life improved enormously after excision of endometriosis. And then they looked at among these 8,000 patients to see which patient did not improve after the surgery. And the only group of patients who benefited less as in the quality of life after excision of endometriosis was the group of patients who had repetitive surgery. So if they have one surgery, two surgery, three surgery. So that brought me, at least, and some few other endometriosis specialists to the principle that if we excise endometriosis, we have to aim to excise all of the endometriosis. And therefore, a lot of the time when we do the first look laparoscopy, we assess the disease first. And then if the time allows, if it's like it needs 2 hours operation, 3 hours operation, then yes, we excise it there and then. But if the endometriosis is too extensive and requires 6 hours operation, or if it's on the bowel and we need bowel surgeon to be with us, then it's better to assess it and book the patient to have bigger operation rather than doing half job to remove part of it and leave parts, because that will mean that this patient will improve less even in the next surgery. And the main reason that they don't improve after repetitive surgery is that the scarring from endometriosis with the scarring from the operation itself will make it hard in the future surgery to tell what's the disease and what's the scarring. Generally speaking, the risk of recurrence if endometriosis is excised, which means removed properly, the risk for recurrence within 8 years is only 4%. And
wow,
that if the patient uses hormonal suppression within this 8 years. So if they take the mini pill or they are pregnant, the risk for recurrence is very low, it's only 4%. And this risk becomes 20% if they are not on hormonal suppression. So within 8 years, there's 1 out of 5 chances that there will be recurrence of endometriosis if they are not on hormonal suppression. Therefore, what I normally say is that if there's a patient with endometriosis and I'm happy that I've excised all of the endometriosis, I normally tell these patients, I would advise you to either be on hormonal suppression, either the mini pill or the diagnoses tablets, or to actively try to conceive, not just like to wait for the pregnancy to happen by chance or something like this. Then the chance of recurrence will be higher. And the choice will be up to the patient, obviously, to decide.
Yeah. And my last question, I did have loads more, but they have all been answered through the discussion. And the last one is, someone has been fitted with the Mirena coil and still gets a regular blood flow. Is it normal to receive this normal menstrual cycle with that hormonal, with the Mirena coil, or what does it mean?
Yeah, so the Mirena coil is a device that delivers progesterone to the lining of the uterus. And as I said earlier, it's the lowest way, or the way the hormonal suppression with the lowest amount of hormone delivered to the patient. For the first 3 to 4 months, a lot of patients will have irregularity in their periods. It does make the periods lighter, but prolonged and more frequent for the first 3 to 4 months. After 4 months, 80% of women will have no period or light infrequent period. But there is still 20% of women that will continue to have problems with the heavy periods, irregular periods, etc. What I have just explained about the Mirena is not specific for endometriosis patients. This is like a general information for any female patient. With endometriosis, my judgment of the Mirena is that it's often helpful, but it's often not enough to suppress the endometriosis because it's so small amount. And even with adenomyosis, which is the endometriosis affecting the muscle of the uterus, Mirena is a very good device, but it's often not enough. Patients often need the mini pill on top of the Mirena, or the diagnoses on top of the Mirena, to have a slightly more hormonal, stronger hormonal suppression.
Thank you. That's really, really interesting and helpful to know.
Pleasure.
Thank you so much, guys. That was really interesting. Some brilliant answers there and great questions. So I think I am going to wrap it up here. So thank you to our panelists for joining us today, and to our audience for sending in such brilliant questions. If you have any further questions for either our panel guests, then please do leave them in the comments box below, as we would love to hear from you. And until next time, take care.